Well, good afternoon. This is Mark Skidmore. I'm the director of the North Central Regional Center for Rural Development, and welcome to today's webinar, Integrating and Sustaining Financial Capability Services in Rural Healthcare Delivery. Before I introduce the speakers and the topic, I want to just share with you our upcoming webinars just real quickly. The very next one will be in the new year in January 23rd, addressing power and asymmetries in community development, looking at the different differentials in power across different parties when it comes to making economic development decisions and bringing in companies and firms and having resources. So that'll be the next one, and then you can see the other two as well. So please mark your calendars for that. And today's webinar, we have a group of researchers from Iowa State University, University of Wisconsin, Michigan State University, North Dakota State University, and Kansas State University. And so the group is actually here with the whole group is here with us today. Suzanne Bartholomew, Michael Collins, Carol Janey, Carrie Johnson, and Elizabeth Kiss. And I think this is a very important and timely topic. One of the largest financial stressors for families can be health-related expenses and challenges. And so that's what the topic of this webinar is about. Although financial capability support services are available in many rural communities, financial education, coaching, and related programs are not well integrated into health systems. So the project explores rural healthcare providers' perspectives on screening patients for such financial difficulties, as well as the potential of sustaining these services. So the project helps inform strategies to support financial capability services integration into rural healthcare systems. And so with that, I'm going to pass it on to the presenters. It'll be primarily Elizabeth Kiss and Suzanne Bartholomew speaking, but the others may also join in. So thanks to all of you for your work on this project and sharing it here on the webinar today. And I'll pass it on to you.
Thank you, Mark, and welcome everyone. First, we'd like to thank the North Central Region Center for Rural Development for the opportunity, the funding provided us to pursue this project, as well as for the opportunity to present about the project today. And have a question that we would like the participants on the webinar, and welcome to all of you, to respond to in the chat box. And we'd just like to know a little bit about your interest in today's topic. I recognize a couple of the names, and so I might have an idea why you're interested, but I'm curious. So if you would feel comfortable just letting us know in the chat box about your interest in the topic to make sure that we address your interests to the extent we can, given what the project was. So if anyone, oh great, Lori is typing. And we'll probably continue, but then as folks have had a chance to type, we'll come back to that. So Mark introduced the team, and again, I'm Elizabeth Kish, and Suzanne Bartholomew will also be presenting, but Michael Collins, Carol Janey, and Carrie Johnson are also with us and are poised to answer questions. I personally, and I think the rest of the team, we'd also like to thank Michael and the team at the University of Wisconsin for their project management as the lead institution on this grant. They kept us all moving in the right direction, and much appreciated. Looking in the chat box, I see that Lori's working with opioid projects in rural communities and teaching financial topics, so that's definitely probably related to what I'm sure we can respond to your interest. And also Brenda's been working with Carol, so you probably know about some things we'll be talking about. So now we do have a second question, and then this is just kind of to get our brains going, everyone on the same page, and then we'll present, and then we'll have another question toward the end. But and I think you've probably both answered this already, Laura and Brenda, and Stephanie, if you'd like to weigh in, please feel free. But we want to know if you've worked with a healthcare provider to collaborate on programs? And if you have, can you please describe your collaboration? So as we think about the project overview, the purpose of the project, as Mark has also introduced it, is that we did really want to investigate opportunities to strengthen partnerships between rural health systems and financial education services. And our team investigated healthcare providers' perspectives about patient financial capability, and then also explored an insurance reimbursement model for potentially sustaining these services. You can see from the quote on the slide, and this is a quote from a focus group participant, and as we'll explain as we go forward, our participants were all healthcare providers. So this provider said and reinforced our intuition that there is a desire among providers to help patients to the extent that they can. And the providers do worry about the financial concerns of their patients. As we think about the nature of the project, and as both Lori from Minnesota and Brenda Bean in Michigan have shared, and across our 5 states, extension educators in several states in the North Central region have been delving into the links between health and household finances. And although financial capability support services are available in many rural communities, financial education, coaching, and related programs are not well integrated into health systems, as we know. But at the same time, there is a growing body of research that shows that financial strain undermines people's ability to follow through on medical treatments, and this can ultimately harm their health. Our findings do underscore this recognized need for financial education services for patients, and the findings also provide valuable information about the capacity requirements and the supports that will be necessary to achieve an integrated, sustained partnership that supports rural community health. Moving now to our methodology, it did have 3 components. We conducted focus groups, we used an online survey, and then one component was a feasibility test. The research team leveraged partnerships with extension offices across our 5 states, as well as relationships with healthcare organizations to recruit providers to participate. And again, our participants were healthcare providers. The 3 components of the methodology, the focus groups and a 13-item online survey, were used to gather input from healthcare professionals about 3 core topics. And those topics are on the slide, but they are, just to say them out loud, to provide observations of the influence of financial capability on patients' on patients' healthcare access, to learn about their knowledge of current resources or potential lack of resources that support patients' financial capability, and also to investigate providers' attitudes and suggestions that they might have for integrating financial capability services into healthcare systems. There were 4 online focus groups conducted in 2 states, Iowa and North Dakota, and then the online surveys were conducted in Kansas and Wisconsin. And survey respondents included 17 providers from 17 Wisconsin counties, providers from 24 Kansas counties, and actually we did get 1 provider from Oklahoma, a bordering state with Kansas. The 3rd component of the feasibility study was conducted in Michigan with a community health center. And that's what this slide talks about. And again, this addressed the second major goal of the project, which was to identify, develop, and test a sustainable billing process that could operationalize financial education and related interventions as integrated billable healthcare services. And this portion of the project was led by the Michigan team, and they did partner with Community Mental Health, which is an organization in Michigan. And the Michigan team researched current procedures for Medicaid billable services as they relate to other medical procedures. They determined the procedural requirements for financial capability billable services and tested the feasibility of implementation within Medicaid patient services by community mental health. The first set of findings that we'll discuss relate to the influence of financial issues on patients' healthcare access. And you can see that the majority of providers did recognize or do recognize the influences of financial capability on their patients' healthcare access. In terms of the surveys, the majority of providers were very or extremely concerned about their patients' out-of-pocket costs. They also said that within the past month, they had a patient who skipped a recommended treatment because of the costs, who did not fill a prescription because of the costs, and they also had patients within the past month who did not get mental health care because of the costs. And now Suzanne will talk about the remaining findings.
Thanks, Elizabeth. And just an FYI, this is the first slide of four slides on the findings that we're going to talk about today, and then we'll end with a summary and a summary slide and a conclusion slide. So if you would bring your attention to the right-hand side of the slide, the focus group discussions really support the findings that Elizabeth just described. The healthcare providers shared many stories about the financial hardships and some of the tough trade-offs that patients have to make. And you can see in the first bullet that one focus group participant described how patients have to make sacrifices and choices about their healthcare. Healthcare costs, particularly co-pays and deductibles, results in patients not getting needed treatment. And the data of our healthcare providers is in line with previous studies that highlight how out-of-pocket expenses can create or amplify financial hardships, which again forces patients to make some tough decisions. We started our focus group discussions with just a general question about the healthcare providers' perceptions of financial security in their patient populations, and we had some really great discussions. They said that their patient population it varied quite a bit in terms of financial security, but the majority of the stories that we heard described a patient population that lacked job opportunities, they made low wages, and as you can see from the quote, the second bullet, that we heard the term living from paycheck to paycheck a number of times during the discussions. So for both the survey and the focus group data, we found that healthcare providers, they are concerned about patients' financial security, and they're concerned about the negative impacts that it has on health and access to healthcare. Providers identified not only the cost of healthcare, but a lack of transparency of health insurance costs as an issue for themselves and for their patients. So about 6 in 10 survey respondents said that it was not at all easy to find information about their patients' out-of-pocket costs. And the focus group data supported this. You can see in the second bullet that one focus group participant pointed to high deductibles preventing needed treatment in some patients. We heard several stories from the healthcare providers about consumers facing an overly complex and an overwhelming process when they try to access and pay for care. We heard about hassles that are involved in getting care, like there being lots of different phone calls that are required, lots of paperwork, and just the wherewithal that is required for a patient to stick with and follow through to get care. The fourth bullet presents a quote that describes how patients have to jump through lots of hoops to access care and how they don't get clear answers about the cost of their health care. So another main finding based on our project data is that providers recognized a need to support patients' financial capability, and they thought that resources and tools to help understand healthcare costs and to navigate and access care would be helpful. During our focus group conversations, it was really interesting to learn about what community resources healthcare providers knew about. And they basically described a range of basic needs, from food stamps, food pantries, free transportation for appointments, but they also mentioned legal aid, WIC, and charitable care. The hospital resources that were available to address patient financial issues included caseworkers and, in some cases, financial counselors. However, they do tend to be underutilized, according to our participants. The hospital admissions and discharge process were identified as points where a patient's current financial stressors are either asked about directly or where they emerge during planning. Healthcare providers identified several barriers that prevent them from addressing their patients' financial security needs or screening patients for financial difficulties. First, healthcare providers don't feel comfortable with providing support to their patients around financial issues. Part of this is due to their lack of confidence in their financial management. And we see this with other professionals like K through 12 educators who have to teach financial literacy, or frontline social service workers who have to deal with financial issues with their client populations. In the second bullet, one nurse described her staff as picking up extra shifts to bring in additional income, and she went so far as to describe them as horrible financial managers. So not only do they not feel confident, they don't feel competent either. We also heard, and this isn't a big surprise, but the healthcare providers want to focus on healing and recovery. And talking about money isn't what they're trained to do. So when someone's getting care, they feel like it's just not the time or the place to bring up financial concerns. Another issue preventing healthcare providers from addressing their patients' financial needs was the issue of time constraints. And the fourth bullet is a quote from a nurse who said there wasn't enough time in the day and described it as impossible to address finances given all of our other responsibilities. So even though our healthcare providers were able to identify some community resources, as I mentioned, about the basic needs and things, many of them indicated that they were unaware of resources. And you can see in the last bullet, one of the focus group participants said, "I don't always know what resources are available. We could help facilitate some of these programs, or at least getting them in touch with people that are going to get them the help they need." And this quote for us really highlights the gap and the opportunity for extension to help provide support to healthcare providers, whether it's increasing their personal financial capability or their ability to provide financial capability resources to their patients. So the second part of our project was the feasibility study. And so Carol Janey, as we mentioned, is our colleague in Michigan, and she worked with the Rural Community Health Agency to learn about procedures for Medicaid billable services for financial capability programming. And Brenda's on the line here, and I know she helped out with the project too. So this part of the project is exciting because it explores a model that would reimburse many of us for the work that we do, which we know in extension is the holy grail, right? So based on the feasibility study, there does appear to be an opportunity for a Medicaid reimbursement model for sustaining financial capability programming. However, there are several barriers that need to be overcome first. So as a background, there's a national standard for uniform coding of medical services and procedures that are available to Medicare and Medicaid beneficiaries. This is updated annually, and in 2016, financial education was coded as a Medicaid billable service for adults with severe mental illness or cognitive impairments. So Carol's work uncovered some contractual and referral regulations that do create implementation issues for a Medicaid billing model. In terms of contractual issues, an extension educator who provides financial capability services would need to have a contract with the community mental health organization that they partner with, and the extension educator who provides these financial capability services would need to apply for a provider status. The model would also require that an extension professional is credentialed. And so at a minimum level, and in most cases I think extension professionals meet these standards, they have to have a high school diploma, they have to have citizenship. So it just depends on what services are provided in terms of what they would qualify for and what credentials would be needed. Another issue with the billing process is that financial education programs would need to be incorporated into the health goals of the patient. So an extension educator who's partnering with a community mental health agency would have to work really closely with that case manager, who would be the person authorizing and referring a patient to financial capability services. The final, and I think the biggest barrier that was uncovered, is the fact that there's limited Medicaid dollars that are available for a community mental health agency to bill for. So they're allowed only a certain amount of dollars. And for some healthcare providers, they may be resistant to putting, these scarce Medicaid dollars towards financial capability services at the expense of mental health services. So this is, I think, of all the implementation issues and potential barriers, this is probably the most difficult. So in summary, we used a multi-state approach to gather some healthcare providers' perspectives, and this approach allowed us to create more robust findings about the feasibility of integrating financial capability services into the healthcare system. Based on our survey and focus group findings, we found that healthcare providers recognize that finances affect health and access to healthcare. We found that healthcare providers don't feel well positioned to address their patients' financial needs, but they do recognize the importance of financial security among their patients, and it's an area of concern to them. Their healthcare providers are really interested in ways to refer patients to financial support resources, and they indicated in both the surveys and the focus groups that they were willing to share materials and resources if they were available. Based on our feasibility study, we found that there's a structure in place for billing Medicaid for financial capability services, but we also found that there were several barriers to implementing such a reimbursement model. So I want to pause for a second, and our next chat box question is, to what extent do you agree that healthcare providers will be an effective partner for extension? And you can say agree, disagree, somewhat, or strongly, however you feel about this, but in your opinion, whether or not you feel healthcare professionals would be a good partner. And in conclusion, our project activities were intended to help us find ways that we can enhance and sustain our work, especially in rural areas. The project showed that based on the data gathered from several North Central region states that there is an opportunity for collaboration between extension educators and healthcare partners. We think healthcare partners could benefit personally from financial capability programming and professionally by learning about the availability of resources and referrals for their patients who are having financial difficulties. State extension systems vary in their tradition of cost recovery and whether participants have to pay for programming. And for many of us, we're always in search of a way to make our extension work sustainable. So this project allowed us to conduct a feasibility study to explore how we might implement this Medicaid reimbursement model and help us sustain our work. As I mentioned, we did find some barriers, that we did only look at a very specific population, Medicaid-eligible patients with mental health issues or cognitive impairment. There may be other populations that we could target that would more easily support a reimbursement model. So in conclusion, as Elizabeth started with, the connection between people's physical and financial health and well-being has really gained increased attention among healthcare providers, among financial capability scholars and educators, policymakers and advocates, and our project contributed to this work. So that concludes our presentation of the project, and again, we appreciate the funding that we received from the North Central Regional Center for Rural Development. The Small Grants Program really helped us, I think, understand where we might be able to fit our programming and extension work into the healthcare system and explore ways to find the feasibility of sustainable, billable services. So we really appreciate you tuning in today, and we are going to take questions if you have any.
Yeah, okay, thank you. If you do have a question, you can just put it right into the chat. And also, while you're thinking about those things, really appreciate your feedback on the, you can see the evaluation thing there. So please take a moment to fill that in. I have a question. For those of us who have healthcare insurance, we don't always think about the complexity that can emerge with major healthcare issues and thinking about, what resources are available. So it is a very complex system, whether you're going to pay for it yourself or whether you have insurance or Medicaid or maybe a state program, or in case of long-term care, there might be other types of insurance. And so it is a very complex kind of environment. And have you, in any of your discoveries, are there any kind of maps available at some of the healthcare facilities to help people identify and walk through various options for assistance, etc.?
I I will start in my I think I'm not aware of maps. I think that there are tools that are becoming available for consumers to be able to price out some medical procedures. But in terms of maps at actual hospitals or clinics, not that
Yeah,
I'm aware of. I'll defer to my project partners if they're aware of maps or
I'm
tools. Like I said, they are trying to become more transparent, but
it is a challenge. I'm just thinking of a particular case in which I have a family member who it looks like this person will be in long-term care, and at some point Medicare expires, but there's another program in that state that can help. But fortunately, the healthcare entity said, to my family member, there's this option that can be a resource for you, because it's quite expensive for the long-term care. But I'm not sure that, my family member would have known to ask about this particular state program if they hadn't said you should apply for it.
Excuse me, this is Dr. Janney. I think maps would be really helpful, and I think they need to be divided into two categories. One for those who are Medicaid eligible, and for those who are not. And it's actually the people who are not Medicaid eligible that it's probably uncharted territory that is very difficult to find the funding and the resources that you need.
Thank you. I
And
don't see.
this is Carrie. I was just going to say, and each site, like you said, it was a state program. So that's what makes it very difficult, because it can't be consistent across the nation or across even probably healthcare providers. So working with each healthcare provider, each location to develop something that is specific to their patients would be important as well.
Yeah.
I guess I might respond. It sounds like, Mark, you mentioned Medicare, so it sounds like maybe it's an older person. And so the Senior Health Insurance Information Program, though, does, a trained counselor can do a lot of that, but in terms of a written map, no.
Yeah.
But also, you were talking, or we were talking about transparency. I guess Suzanne mentioned transparency of cost, and that's something I've just personally been trying to do when I go to a provider, like my primary care physician, and they say, oh, you should have this done or that done, and then I try to get them to tell me how much it will cost before I sign all the paperwork to go into the waiting room. And it's very interesting, the number of phone calls that they have to make, but they do usually come up with a pretty good estimate, at least my experience recently.
Yeah, it's funny, if I take my dog to the veterinarian, I can see all of the prices of every type of procedure, and even ranging from, if it's a surgical procedure, whether you use a laser scalpel or a traditional scalpel, and the technology is better, with the laser scalpel, so it's more expensive, and there's a very specific price to every type of animal health procedure, but it's much harder in the human side.
and
Yeah, I
I
took I was going to say I took my daughter in, and she has to have surgery, and I've been given it'll be $10,000 to $50,000. But you have insurance, so you know your maximum out-of-pocket cost. But it'd be nice. That's a $40,000 difference. Is it going to be 10 or is it going to be 40?
Wow. Yeah, these are very challenging. It's a very complex system, and the transparency just isn't always there, and it takes quite a bit of work to figure out what things cost as well as what resources are available. And it's and healthcare expenses are a major contributor to family bankruptcies as well. So,
And I was going to jump in and say that the range of consumer, when you look at the consumer and their range of skills in terms of advocating for themselves, particularly in healthcare, the healthcare arena, that it's not, I don't think it's second nature to most people to ask the right, ask these difficult questions of how much is it going to cost, to look at different forms of payment, and I hope that we start to shift that way just because we're having such difficulty with health insurance these days and health insurance coverage and what is covered. So I think really empowering consumers could go a long way in addressing some of the issues that we see in the marketplace.
yeah. I don't see any additional questions coming in from the participants, so maybe this is a good spot to stop for this afternoon. Thank you very much to all of you for your work and for sharing, and I think it's a step in the, a nice contribution to kind of highlight some of these issues and concerns and maybe make some progress towards increased transparency on these issues.
Thank you.
Yeah. Well, we'll close off for now, and thanks again, and thanks to the participants for joining us. Have a good afternoon.